Okay, let's unpack this. Right now, you're breathing, probably not even thinking about it.
Mm-hmm. In and out.
Yeah, it seems so simple, right? But mechanically, it's this incredible balancing act. There's physics involved, like how stretchy your lungs are and how much friction the air encounter is moving through.
Exactly. And those two things, the stretchiness and the friction, are what we call compliance and resistance. They're, fundamental to how our lungs actually work.
And that's what we're diving into today. We've gathered a whole set of materials research, clinical notes that break all this down, the definitions, the calculations, and critically, why it all matters for, respiratory health.
Yeah, we want to make these concepts clear, show how they're measured, and really connect them to what happens in the body, both normally and when things go wrong. Think of it like getting under the hood of your breathing engine.
Okay, good analogy. Let's start with the first one then. Compliance. What is it in simple terms? Simply put, is how easy it is to stretch the lungs. It's a measure of their elasticity. Specifically, how readily those tiny air sacs, the alveoli, inflate.
So like a balloon, how easily it inflates.
Pretty much. The more technical definition from our sources talks about the distensibility of the lungs and the chest wall together. It's about how much the volume changes for a certain change in pressure.
Okay, volume change per pressure change. So if they stretch easily, compliance is high.
Exactly. There's this inverse relationship with elastic resistance. If the lungs are less stiff, meaning lower elastic resistance, compliance goes up. If they get stiffer, elastic resistance increases and compliance goes down.
And there's a formula for this, right?
Yep, it's straightforward. Compliance equals the change in volume divided by the change in pressure. Delta V over delta P.
Simple formula, but it sounds like that number tells you a lot.
Oh, absolutely. Because if compliance is way off, either too low or too high, it really messes with gas exchange. It's often a big reason why someone might need mechanical ventilation. The system's quite sensitive. Okay, let's break down those extremes. What about low compliance? The sources call it stiff or non-compliant.
Right. So with low compliance, you need a big change in pressure just to get a small increase in lung volume. Think about trying to inflate something really stiff.
It takes a lot of effort.
A lot of effort. That's an increase in the work of breathing, the WOB. It can also lead to really stubborn low oxygen levels, refractory hypoxemia. It's often linked to conditions that reduce the FRC, the functional residual capacity. Basically, the air left after you breathe out normally makes it hard to open the lungs up.
So the stiff balloon analogy holds up. It's hard work.
Definitely. Now, flip side, high compliance.
So that's like a really old, saggy balloon, easy to inflate.
Kind of. You get a large volume change for only a small pressure change. So yes, easy to get air in. The problem is getting it out.
Okay. Why?
Because they've lost that elastic recoil, that springiness needed to push the air out effectively during exhalation. Think of emphysema. That's a classic example. These conditions tend to increase the FRC because air gets trapped. Patients often have obstructive issues, airflow limitation on the way out, incomplete exhalation, and poor gas exchange because of it.
So whether they're too stiff or too floppy, efficient breathing suffers.
That's the bottom line. And, in a clinical setting, especially with the ventilators, we measure compliance in two main ways to get a clearer picture: dynamic and static.
Okay, dynamic and static. What's the difference in how you measure them?
The key is airflow. Dynamic compliance is measured while air is flowing into the lungs during the actual delivery of the breath.
Okay.
Static compliance is measured after the airflow stops. We typically do this using an inspiratory pause on the ventilator. Just hold the breath in for a brief moment. No flow, no active muscle effort from the patient.
Got it. Dynamic with flow, static without. And they use different pressure points.
Right. For dynamic compliance, or CDYN, we use the peak inspiratory pressure, PIP. That's the highest pressure reached during inspiration while air is moving. Because flow is happening, CDYN is affected by both the lung chest wall elasticity and any resistance in the airways.
Okay, so it includes resistance.
Exactly. The formula is the exhaled tidal volume divided by the difference between peak pressure and PEEP, that baseline pressure. Normal CDYN is usually around 30 to 40 millicmH2O.
And static compliance, CST.
That one uses the plateau pressure, or PL8. That's the pressure measured during that static pause when there's no flow. And this is crucial. Because there's no slow, airway resistance is not a factor here.
Ah, okay. So it isolates the stretchiness.
Precisely. CST reflects only the elastic properties of the lung and chest wall. Sometimes it's even called elastic resistance. The formula is exhaled volume divided by plateau pressure minus PEEP. Normal static compliance is higher, more like 60 to 100 millicmH2O. And it's really useful clinically for figuring out the best PEEP setting.
So dynamic is the whole picture resistance plus elasticity. Static is just the elasticity.
You got it. And that difference is really important diagnostically. Generally, if something affects the lung tissue itself, making it stiffer or floppier, changing static compliance, it's usually going to affect dynamic compliance too.
But there's a key exception.
Yes. And this is where it gets really useful. If the only problem is increased airway resistance, like bronchospasm or a blocked tube, then dynamic compliance might drop. But static compliance can stay perfectly normal.
Because a static measurement takes resistance out of the equation.
Exactly. So if you see CDYN fall, but CST stays stable, instantly, okay, the problem is in the airways, not the lung tissue itself. It's a really powerful clue.
That makes sense. And I see the sources emphasize looking at these numbers over time, not just once.
Absolutely essential. Trending is everything. A single number is just a snapshot. The trend tells you if the patient's improving, getting worse, or responding to treatment.
So what kind of conditions typically cause that static compliance to drop, the stiff lung issues?
Yeah, our sources list quite a few common ones. Things like atelectasis, collapsed lung areas, ARDS, acute respiratory distress syndrome, attention pneumothorax. Obesity can do it, just the weight pressing down.
Makes sense.
Retained secretions causing blockages, pneumonia, pulmonary edema fluid in the lungs, also chronic things like fibrosis or scarring, and even deformities of the chest wall itself.
And all of those would likely lower dynamic compliance too.
Generally, yes.
Yeah.
But remember, dynamic compliance will also drop if you only have increased airway resistance, even if static compliance is fine. So things like bronchospasm, a kinked breathing tube, any kind of airway obstruction, those hit dynamic compliance directly.
Okay, so CDYN is sensitive to both stiffness and resistance, while CST mostly tells you about the stiffness.
That's the core distinction, and it's why measuring both gives you so much more information.
And focusing back on that stiffness, the decreased compliance, what's the direct impact on the patient's effort?
It always increases the work of breathing. Always. Takes more energy, more muscle force for the patient or the ventilator to move air into those less stretchy lungs.
And if the patient can't compensate for that extra work,
And you often see hypoventilation. They just can't maintain adequate breathing to clear CO2 and get enough oxygen because it's simply too much work. It's exhausting.
okay, that covers compliance, the stretchiness factor. Let's shift to the other side of the equation, resistance.
Right. Resistance. This is all about the opposition to airflow as it moves into the lungs. You need a pressure gradient to get flow started, right? Air moves from high to low pressure, but as it flows, there are forces fighting against that movement. Frictional forces.
And where does that friction primarily come from?
Our sources break it down. About 20% is what they call tissue viscous resistance, basically. The friction from the lung and chest wall tissues rubbing against each other as they move. But the big one, the other 80%, is airway resistance, usually abbreviated as RAW. That's the main player we focus on.
80%. Okay, so what determines how high that airway resistance is?
Several factors. The viscosity of the gas matters. Thicker gas, more resistance, but normally we're breathing air, so that's pretty constant. The length of the tubes, longer airways mean more resistance. The speed of the gas flow, the velocity faster flow creates more friction, so higher resistance.
But the big one, according to the sources, is the airway size, the radius.
Oh, absolutely. This is the critical factor. Think about it. As an airway gets narrower, the gas molecules have less space, they bump into the walls more, friction goes way up, and it's not just a linear relationship. Quoisuy's law governs this, and the impact is exponential.
Exponential. How so?
Get this. If the radius of the airway decreases by half, just cut in half, the resistance increases 16 times.
Wow, 16. Just from having the diameter.
16 times harder for air to flow through. Think about trying to drink a thick milkshake through a tiny coffee stirrer versus a wide straw. That tiny change in radius makes a massive difference in the effort needed.
That really drives home why something like asthma or bronchospasm, where airways narrow, can become so dangerous so quickly.
It's incredibly dramatic. And just like compliance, we can measure airway resistance.
Okay, how do we calculate RAW?
It uses those same pressures we talked about. RAW is calculated as peak pressure minus plateau pressure divided by the airflow rate, usually measured in liters per second.
So that difference between PIP and PLET is directly related to the resistance.
Exactly. It represents the pressure needed just to overcome the airway resistance during flow. Normal RAW in someone breathing spontaneously is very low, like 0.6 to 2.4 centimeter H2O per liter per second.
Very low. But what about someone on a ventilator with a breathing tube?
Right. The tube itself adds resistance. So for an intubated patient, a higher range is expected, maybe up to 15 centimeter H2O sec is considered acceptable.
Yeah.
But the source is caution, even if it's in that acceptable range. If it's elevated, say over 10, the clinician should definitely be investigating why and trying to fix it.
What kinds of things can be done to lower airway resistance?
Well, the basics. Suctioning out secretions, making sure the airway is clear, sometimes adjusting ventilator settings, like using a lower inspiratory flow rate, can help. And then medications, bronchodilators to open up constricted airways, maybe steroids to reduce inflammation.
And what conditions are classic causes of high airway resistance?
All the obstructive diseases, for sure, asthma, COPD, chronic bronchitis, but also physical blockages. Could be something after intubation causing narrowing, maybe someone inhaled a foreign object. Even just condensation building up in the ventilator tubing can increase resistance. Or a kink in the breathing tube itself.
And in people without a tube?
Infections that cause swelling and narrowing of the airways are common culprits, things like croup, epiglottitis, or bronchiolitis, especially in kids.
Okay, so this really loops back beautifully to those pressure measurements, PIP and PLA. Understanding how they relate to compliance and resistance seems key.
It absolutely is. This is where the mechanics turn into really practical diagnostic information at the bedside. First, a fundamental check. Peak pressure, PIP, must always be higher than plateau pressure, PIT, always. If your measurement shows PIT equal to or higher than PIP, something went wrong with how you measured it.
Okay, PIP always higher than PIT, and mathematically that means dynamic compliance must always be lower than static compliance, right?
Correct. Always check that relationship holds true before you even interpret the numbers. Now let's think about changes. If plateau pressure goes up, what does that tell you?
That means the lungs or chest wall are getting stiffer. Static compliance is decreasing.
Right. And if PI goes up, PIP almost always goes up too, because you need more total pressure to push air into those stiffer lungs, even overcoming the same resistance. They tend to move together when the problem is stiffness.
But the really interesting diagnostic part is when they don't move together.
Exactly. This is the money shot, diagnostically speaking. If peak pressure, PIP, goes up, but plateau pressure, PLAT, stays the same or changes very little, what's the only thing left that could cause that?
It has to be airway resistance. Because PLAT isn't changing, the lung elasticity is fine. But PIP went up because more pressure is needed to overcome friction during flow.
Precisely. That pattern rising PIP with stable PAT screams airway resistance problem. It immediately tells the clinician, check for secretions, listen for wheezing indicating bronchospasm, check the breathing tube for kinks or obstructions.
That's incredibly useful.
It really is. And it also relates to how we set ventilator support. Our sources mention that pressure support, which helps the patient take spontaneous breaths, is often set to match or exceed the calculated airway resistance, specifically to help overcome the extra work imposed by the breathing tube and the ventilator circuit itself.
So pulling this all together, why should you, listening right now, care about all these mechanics, compliance, resistance, PIP, PLAT?
Well, because understanding these core ideas is, I think, essential to really grasp how breathing works day to day, and more importantly, what's going wrong when someone develops a respiratory illness. These aren't just abstract numbers. They are tools used constantly, especially in hospitals and ICUs, to figure out what's wrong with the lungs.
They guide treatment, right? Help see if things are working.
Absolutely. Is the bronchodilator helping? Did clearing the secretions lower the resistance? Is the PIP level improving compliance? These measurements give objective answers and paint a picture of the mechanical stress the body is under. It gives you a much deeper appreciation for the physics behind every single breath.
It's not just air moving passively. It's this dynamic interplay of forces.
Exactly. So we've covered compliance, that's the stretchiness. We've covered resistance, the opposition to flow. We've seen how measuring them, especially teasing apart dynamic and static compliance using peak and plateau pressures, gives us these vital clues.
And we've seen how any shift in that balance, lungs too stiff, too floppy, airways too narrow, makes it harder for the body to do its most basic job.
Yeah.
Move air and exchange gas effectively.
Yeah. It makes you think, doesn't it? Our bodies manage this intricate balance of compliance and resisting so perfectly most of the time that breathing is completely effortless, unconscious. Yet, as we've discussed, even small changes in these mechanics can turn that simple act into a life-threatening struggle. It really makes you wonder, what stands out most to you when you consider the sheer mechanical precision required for something as simple as taking a breath?